everyone, and welcome to Back on Track, a Return to Work Toolkit. My name's Isabel Berwick. I lead the Financial Times Working It brand. I write, speak, and make videos about the workplace, the future of work, leadership, and management. So I'm going to give you a few technical notes before I introduce our two very distinguished speakers today. Subtitles are available for this event. To turn them on or off, just click the CC Show Captions button at the bottom of the screen. If you're watching live, you can submit questions throughout the event in the Q&A bit. It's available throughout the event, so don't worry about posting them. We'll come to them at the end, or if it's very pressing, maybe during. And please also remember that today's event's being recorded, so you can watch again at any time. So our speakers today are Simon Gilbody, who's the Professor of Psychological Medicine and Epidemiology at the University of York and the Hull York Medical School. Simon's a practicing NHS psychiatrist and cognitive behavioural therapist. Unusually, he's also a Professor of Epidemiology, and he's among the top 1% of most highly cited scientists in the world. During the pandemic, Simon's team led the largest ever trial to tackle loneliness at scale, and the results are useful in thinking about how we can prevent loneliness in the post-pandemic workplace. Dean McMillan, our second expert, is Professor of Clinical Psychology at the University of York. He's interested in developing and evaluating psychological interventions that can be delivered at scale for common mental health problems. He's worked on a number of randomized trials of such interventions, including some focused on depression, anxiety, and loneliness. I can't think of any two better speakers to bring some life and insights to this subject. So I'm going to hand over to Simon and Dean, who are going to present and talk. I'm going to have a chat to them, and then we'll invite your questions. So Simon and Dean, over to you.
So it is a real honour to be here. I've got to say, I'm excited to be invited to speak about mental health in the workforce. And I am especially excited that this session is being chaired by someone as interesting and curious as Isabel Berwick. So thank you for your gracious introduction. Isabel writes beautifully about work and workplace culture, and I can't recommend her pieces in the Financial Times and her Working It outputs highly enough. It's really great, and I'm also excited to be part of the Festival of Ideas here at the University of York. It's a great way that the university demonstrates its presence at the heart of the city of York, and it reaches out to the rest of the world. So I've got to say that there are people in the audience that I've not heard from for over 30 years who seem to be quite excited about the fact that I'm speaking at the Festival of Ideas and had no idea that I had a glittering academic career. So it's really nice to join up with friends and old friends and colleagues. And just a bit about myself. I'm a practicing psychiatrist in the NHS, 30 years. And just going to get rid of something that's causing an echo on my phone. But I'm also the Professor of Epidemiology here at the University of York, and that's a really interesting thing to do. So a combination of a clinical background, but also an epidemiologist. And before the pandemic, it used to take me about 20 minutes to explain what an epidemiologist was. But since the pandemic, everyone knows what epidemiologist is. I sort of do the same thing as Professor Chris Whitty, but Chris Whitty does infectious diseases. We do common mental health problems. We think about what it is that causes common mental health problems and how we might solve those in society. And we come up with scalable solutions. And I'm pleased to be here with my esteemed colleague, Professor Dean McMillan. And we both sit in a group within the University of York called the Behavioural Therapeutics Lab. And we try to think about what the most pressing problems are in society. And we try to think about how we can use behavioural approaches to try and solve these problems. We spend a lot of time thinking about what works in mental health. And we read the research and do the research so you don't have to. So it's nice to be able to speak about some of the things that we've been doing in the area of workplace mental health. And we hope this will be interesting for you for the next 30 or so minutes. So we're going to talk about how to get people back on track. And if people want to zone out for a few minutes and go and make a brew, I'm going to just highlight what I'm going to speak about in the next 20 minutes and pass over to Professor Dean McMillan. So I'm going to say that mental ill health is the most important driver of long-term inactivity. There's this increasing recognition that this is the case, and it incurs substantial costs to the economy. These are enormous and they're on the rise. And this has framed the position of long-term economic inactivity in a series of conversations that have been emerging over the past 2-3 years. And the NHS's default response is not, in fact, an active intervention, but it is to issue a fit note. And that is not always helpful, and in some cases might be a harmful response for the NHS. So if you think about how the NHS might respond to long-term economic inactivity, we perhaps need to think beyond the fit note. And the good news is that there are effective psychological approaches. Dean is going to speak about those, but the important thing and the consideration today is that really need to be integrated somewhere between the NHS and the workplace, and that doesn't currently happen. And the other important takeaway from today is I hope people leave today's talk with a sense that it's really important to act early, to get in before these problems become entrenched. And to borrow a phrase from Benjamin Franklin, an ounce of prevention is worth a pound of cure. And this is a good time to be thinking about this because there's a white paper in the offing. And I'll think about what it says in the white paper and try to make some helpful suggestions to politicians who are making big decisions just at the moment. So, Dean and I are sort of recovering academics. The university is ever so keen that we try to find ways to translate the insights that we generate in universities to think about how they might impact in the real world. So we've been deprogrammed to think as academics, and we've been trying to program to think in a slightly more entrepreneurial fashion. And the big thing we've taken away from that is that we spend some time defining the problem and then come up with a solution to the problem. So I'm going to be the bad cop in this dyad. I'm going to speak about what the nature of the problem is, the nature of the problem of mental ill health and how this is impacting on long-term economic inactivity. Now, Dean's going to be the good cop and he's going to tell you about how we solve this. And then we'll come together and have a good old discussion with both Isabel and with the audience. So I'm going to talk about how this has become part of the national conversation. So I've got a front page from the Daily Telegraph from just over a year ago, from before the change of government. And there we've got the Right Honourable Member for Richmond and Northallerton, who at the time was the Prime Minister, Rishi Sunak. He's picking a fight with what he calls sick note culture. He's also picking a fight with GPs. He wants to stop them being able to issue fit notes, and there's sort of a hint of people have been getting away with this too long, that people are doing what my dad used to call swinging the lead, that this can all readily evolve into a discussion around snowflakes and people being work shy and idle. So you can see this was framed within a political debate that was happening before the election last year and a change of government. But this discussion's continued and it's now the subject of a white paper. So the Right Honourable Member for Leicester West, the Secretary of State for Work and Pensions, Liz Kendall, has been really busy coming up with some ideas about how we can get Britain working. So you can see this is part of the national conversation. But written right through both of those headlines and the white paper is this notion that depression and anxiety are in some way impacting on our ability to work. So I thought I'd spend just a couple of minutes thinking about why common psychological complaints, the things that I see on a day-to-day, week-to-week basis in my practice in the NHS, might cause what we call presenteeism, difficulties in working efficiently in the workplace, and also absenteeism, and how that might translate into long-term unemployment and economic inactivity. So there are three things that often get named in people's fit notes when they take time off work, and those are depression and anxiety, and sometimes work stress. So I'll unpack those a little. In the first instance, depression, there's a constellation of complaints that people would describe when they become depressed or low in mood that might impact on their ability to work and function in the workplace. And those are often poor motivation. People talk about their get up and go, having got up and gone. And there's also reduced cognitive capacity. People really struggle with attention and concentration. I meet people who say that they begin a piece of work or they start reading a sheet of text and they struggle as they read through each line, and by the time they get down to the bottom of the page, they've forgotten what is said at the top of the page, and it's really difficult to work when that is how your cognitive function is on a day-to-day basis. I meet people who go and speak to their GP and wonder if they're actually suffering from dementia. They ask for tests for dementia, and they're describing this cognitive impairment that is very common as part of this constellation of depression. People often describe chronic insomnia. They lose the ability to achieve restorative sleep. They waken up in the morning unrefreshed, and it's difficult to begin the day again. And there's this thing that's often written in people's GP notes, and that's TATT, tired all the time. It's a very common complaint for people who are experiencing depression. And often people present to their GP with long-term physical health problems and the complaint of pain, and that becomes accelerated and amplified in the presence of depression. And when this sets in, it often leads to workplace absence and at home withdrawal away from social contact. People spend all day in bed. They find it difficult to interact with other people. And this leads to a sense of avoidance that Dean will speak of in a little while. But avoidance, not in a pejorative sense, not in the way that Rishi Sunak might have meant it, but something with a very specific psychological meaning. The other thing that often sits alongside depression is anxiety. Everyone in the room today will have experience of anxiety and experience of that very unproductive worry or rumination where you think about things a lot, but not in a productive way. You don't solve problems. So thinking about a thing doesn't help you get to the solution. And often people speak of very intense over-arousal. So your heart rate going up, breathing very rapidly, getting tingling in your fingers that can often impact on your ability to think and to concentrate. And it's really difficult to perform in the workplace when you feel like that all the time, or when those feelings are triggered by particular situations. And those are often people or places or certain meetings that are in your diary during the week. And this leads to a constellation of symptoms that feel very much like phobias. And when you develop a phobia to something, it's very easy and it's your default response to start avoiding those triggers that cause that, those symptoms. And again, avoidance is threaded through anxiety. It's the natural response of people, and often that can be unproductive and counterproductive, particularly when the sources of phobic avoidance are in the workplace. And the other thing that's sometimes described is stress. And stress isn't a diagnosis all by itself. And in the context of workplace difficulties, these are often proximal to immediate difficulties and adversity in the workplace. So people will commonly talk about situations that they find aversive. So I often meet people in clinical practice who talk about waking up and going to work on a Monday morning and feeling as though they are driving to their own funeral. They park up in the car park and they look around the car park for people that they've having disagreements with in the workplace. and they feel sick in the pit of their stomach, and they experience a whole series of anxiety symptoms, and it takes them 20 minutes to compose themselves before they can actually walk into the office. So these stresses and these adversities are often work-based, and that makes it really difficult. And we can talk about how we might seek to overcome those and what happens when you get situational anxiety. So I spoke about the moral panic that seems to emerge around economic inactivity. So my first question as an epidemiologist is this real? So there are lots of data around that help us think about the extent and the degree to which this is a problem. And it is a problem. And in 2025, if we were to count the number of people who are economically inactive on a long-term basis by reason of a long-term health problem, this amounts to 2.8 million people. And this has increased quite substantially since 2019. So there are now 750,000 more people who are long-term economically inactive compared to 4 or 5 years ago. And this translates into over 16 million lost working days. And the forward projections for what this might mean for the economy is that this might represent £100 billion of an annual cost within 5 years. And to put that into context, that is twice what we spend on educating our secondary pupils just at the moment. So it's more than twice the budget for secondary education. And a large portion of this is attributable to mental and behavioural disorders, as they're called when we collect statistics on this. And the other thing is that mental and behavioural disorders often sit alongside other long-term health problems, so diabetes and musculoskeletal complaints. So this is a thing, and it's on the rise. And I'm going to pinch a slide here from one of Isabel's colleagues at the Financial Times that illustrates really quite nicely. So I've circled the main cause of workplace absence on a long-term basis here at the top. And in the light blue is what the figures were before the pandemic, and in the dark blue is what they were during and towards the end of the pandemic. So you can see that mental and behavioural disorders have increased substantially, and these are the ones that are on the increase compared to the other common causes, which are musculoskeletal diseases. So joint pains, back pain are the other big drivers of long-term inactivity. And if we look at the figures, this is rising in over 50s, and more concerning, I think, is that this is now the leading cause of long-term workforce inactivity amongst under 40s. So my next question would be, is this driven by rising levels of mental ill health? What's driving this? Is it because we're becoming more depressed and anxious as a nation, or is there something else going on? Well, it's complicated. It's not the whole story. So I'm going to pick on some figures again. And one of the things that we're really good at in this country is doing surveys, taking the temperature of the financial and social and mental state of health of the country. So it's the UK household longitudinal study that's called Understand Society that has collected successive waves of data since the early 1990s. And they ask the same questions year on year. And this isn't a standing on the street corner kind of survey. This is a very well constructed survey of 40,000 households comprising about 100,000 individuals. And you can see that for the age group 35 to 64, my age group, it's pretty much flatlined at around 1 in 5 of the adult population reporting mental distress that is of some concern. And it's not really changed over time. I can't show it on this graph, but it did go up during COVID, and it's come back down pretty much to where it was now. If I were to contrast this with the same survey, but looking at the group of people aged between 16 and 34, it does seem to be on the rise. So you can see over at the right-hand side of this graph, in 2015, there's an uptick, and it stayed up, and it went up again during the pandemic, and it's not really come back down to where it was. So this is where the big change is happening in society. It's not in my age group, it's in the age group of my children. So The final slide I'm going to show, I think, illustrates something about what happens after someone receives a fit note at work and how things change in the year following the issue of a sick note. So here I've got a graph with a red line that describes 100 people who receive a sick note and what happens in the year following the issue of that fit note. So along the bottom here, we've got calendar days away from work, going up to just over a year, and going up on the upwards axis is the proportion of people, the number of those 100 that have actually got back to work. And you can see that all the action happens down here in the first month. So within the first 28 days, 80% of people have got back to work within that period of time. But thereafter, the graph changes direction and the chances of a successful return rapidly diminish thereafter. And I think behavioural theory that Dean will speak to is very helpful in helping us to understand this. So that is that avoidance very quickly leads to entrenchment. And once you get entrenchment, it's very difficult to get back to work. And we call this the inflection point. So I'm going to come back to that towards the end. And the important message here is that if we want to make a difference, if we want to change the trajectory of this graph, we need to do something before this inflection point rather than afterwards. So this first month is really crucial if we're going to tackle the issue of long-term economic inactivity. So how might we use these insights before I pass over to my esteemed colleague, Dean McMillan? Well, we can see that there are rising rates of mental ill health, but it's not the whole story. It's not that the whole nation has become more psychologically unwell, but there seems to be an equation at play. So long-term conditions, LTCs, and this would include mental and physical long-term health problems, plus a recent history of no economic activity, really predicts long-term and particularly amongst younger people, lifelong economic inactivity. So I worry that younger people are experiencing stress and anxiety and depression in their first job. No one's looking after them, and then they're falling into long-term economic inactivity, and that begets a life of worklessness. So a fit note is an understandable, but I'm going to say is potentially an avoidant offer from the NHS. And Dean will talk about the importance of avoidance from a psychological point of view. And my take home is that we need to act early in order to prevent absence becoming entrenched. I worry that we are closing the stable door after the horse has bolted, and there might be a bit of this in the white paper. So I will come back at the end and maybe make some helpful suggestions about what might be in the white paper. So now I pass the speaking baton over to my friend and esteemed colleague, Professor Dean McMillan, who's now going to map the solution. He's going to think about acting early and the importance of the offer of behavioural interventions. So over to Dean.
Hello, everyone. Thank you very much, Simon. And as Isabel was saying, so I'm Dean McMillan, I'm Professor of Clinical Psychology at the University of York. What Isabel didn't say, though, was I'm a clinical psychologist and Simon's a psychiatrist, and we're meant not to get on. Psychologists and psychologists are meant to fight all the time, but we don't. In 20 years, never across words. So we've worked together to try to sort some things out. What I'll do is I'll take you through what our intervention is that we've developed up at York, and I'll finish off by saying why we're big fans of it at York, why we really like this approach. Simon, if you jump onto the next slide for me. I guess the starting point is worth saying what the psychological theory is that underpins it. It's operant conditioning. An operant conditioning model is a psychological theory that's as old as the hills. It's a venerable old model. And I guess it's true to say that this is a psychological theory that's been in and out of fashion, but it's never out of style. And it's never out of style because it's still a really helpful way of understanding how you can help people make useful changes to their behaviour that can have a beneficial impact on things such as mood and anxiety. The intervention, then, in brief, it's a guided self-help intervention that's supported by a coach. So a coach helps the person work their way through up to 5 stages that we have in the intervention. I'll come back later on to talk about who the coach is, because that's a really important part of the story. If you want a psychological intervention that you can deliver at scale, you've got to think quite carefully about who's going to be delivering the intervention. And we've thought quite carefully over the years about who can deliver the intervention, how you build an intervention that can be delivered at scale. It's also a telehealth intervention. So you could deliver this, and we've got evidence that you can do this very effectively face to face, but we've also built up the evidence that you can deliver this effectively over the phone. And there's all sorts of advantages for the workplace of having an intervention that can be delivered via the phone rather than having it to do face-to-face psychological treatment. On the left-hand side, we've got a model that we introduce to people early on. So the coach will talk somebody through this model in the first session, and it's trying to give you a bit of a sense of how we might understand why someone's feeling stressed or low or anxious. And the basic story is this. We always say, look, feeling stressed, feeling low doesn't come out of nowhere. It's typically triggered by a life event. That life event might be something at work, but it could be other things as well that are outside of work. And we say in behavioural terms, a life event's a problem for us if it leads to a change in behaviour. If it means we stop doing things that are important or meaningful or valuable to us. We go on to say then, if that happens, if a life event comes along that stops you doing important, meaningful and valuable behaviours, it's understandable. There's going to be some type of emotional response. You're going to feel stressed. You're going to feel low. You're going to feel anxious. So it's an understandable response. Round there on the left-hand side of this cycle is the point Simon was making, that in response to feeling stressed or feeling low, it's understandable that you might slip into some form of avoidance. It's a natural thing for us to do. And that might work for you in the short term. You're putting stuff off, pulling the duvet back over your head, not seeing friends, might give you some short-term relief, but in the long term, it's embedding the problem. It's making the problem worse. And that, in behavioural terms, we think happens in one of 2 ways. One is that central arrow, that if you start putting stuff off, if you start avoiding, you start pulling the duvet back over your head, you're going to engage in even fewer important and meaningful behaviors. You're not interacting with people, you're not socializing. So there's going to be a drop off in those meaningful activities. So you get a vicious cycle set up at the bottom there of this model. But there's also another way putting stuff off and avoidance might cause us problems, and that's that top arrow back to life events. It might exacerbate existing life events, or it could trigger new life events. If you're not getting out of bed, if you're going into work late, you might end up getting into trouble at work, and that's a new life event. That's set up another vicious cycle as well. So that's a basic model we try to introduce early on, with the idea that behaviour, what we're doing and what we're not doing, has an important impact on how we feel. And that gives us some roots in to helping people make changes by focusing on their behaviours. So Simon, if you pop onto the next slide, I can talk you through what those intervention strategies might be. And we boil it down to 4 things. There's 2 R's and there's 2 D's. So the R's are reinstating previous behaviours. So working with someone and saying, well, what behaviours did you used to do that before you started feeling like this, that worked, that helped you in some way, but might have dropped out of your behavioural repertoire? You're not doing at the moment. We gradually schedule those back in to see what impact it has on a person's mood. Sometimes, though, you can't do that. It's not as simple as that, because the life event might mean you can't do those behaviours anymore. So Simon's alluded to the fact that often psychological difficulties go alongside long-term physical health problems. So it could be a physical health problem that's meaning you can't do behaviours anymore. There's certain behaviours that help you stay well that you can no longer do. What we do there is we think about replacing those old behaviours with new ones. So we might talk to somebody about, well, what did you used to do that helped? What was it about that behavior that helped you stay well, that kept your head above water? And then we have a think about other behaviors you could try that might look radically different to the old behavior, but serve the same function, get you the same thing out of life. And we found that to be a really important intervention strategy when people do have comorbid long-term conditions. So that's the 2 Rs. If we just go to the next slide, Simon, I can take you through the 2 Ds. So the first D is working on that avoidance, helping the person spot the avoidance behaviors that might work in the short term, but in the long term are setting up that vicious cycle, and helping the person gradually decrease those behaviors and flipping those avoidance behaviors into approach behaviors. So rather than putting the stuff off, let's sort the problem out. Might feel worse in the short term, but it might sort things out a bit better in the long term. And the final thing we do is we recognize that for all of us, we can all spot behaviors we might need to change, but that doesn't necessarily mean we start doing those behaviors. Sometimes there's an intention behavior gap. So you might have good intentions, but it doesn't turn into the behaviors. So what we do there is we work with people to think about how can you organize your environment a bit? How can you organize your world to trigger those new behaviors, those more helpful behaviors, not relying on getting this internal motivation back, but thinking about organizing your world to make the changes, and then you get your motivation back. And we've got a few strategies to do that as well. So that's the intervention in brief. Simon, if you go on to the next slide, I'll perhaps just talk through why we're big fans of this behavioural approach up at York. Well, one is we've got a really solid evidence base for it. Over the last 15, 20 years, we've done lots of randomized trials of this approach in different settings, and we know it's clinically really effective. It's quite a straightforward intervention, but it gives you a decent clinical effect. So you see improvements in low mood, in anxiety, increases in psychological well-being. And we've got really good evidence for that. That comes from randomized controlled trials. So the same type of evidential base you'd need to bring a new drug to market. So a solid evidence base in terms of clinical effectiveness. We're also really fortunate at the University of York is we've got lots of really bright health economists there. So people much brighter than Simon or me who know how to do the bean counting. They can work out, is this stuff good value for money? Does it give you a return on investment? And the answer to that is yes. It's a really solid effect, not just in terms of clinical effectiveness, but also in terms of cost effectiveness. And the final thing we've done is we've talked to lots of people who've had the intervention. We've interviewed them, and it comes across that it's really highly acceptable to people. Part of that is because we built it with the people who were going to have it delivered. So we talked to people and talked about what the intervention should look like. And the things they picked out in terms of why they liked it is it's fairly straightforward. It's making some practical changes, and it's free of psychobabble. It's very practical. It's not psychobabble. It's not sitting down and talking about your past relationships or anything like that. Very practical, and we've been really careful to take out any of the fancy schmancy psychobabble with plain terms, and that seems to help as well. As I said earlier on, a key thing about this is it can be delivered at scale. We've known for about 70 years now that psychological interventions work for stuff, but not enough people get them, and that's because there's a big rate limiting step. Typically, the interventions need to be delivered by somebody like me, a clinical psychologist, somebody like Simon, a psychiatrist, or we're both CBT therapists as well. But there's just not enough of us to go round, and there's never going to be enough of us to go round. So what we've tried to do at York is take the essence of these psychological interventions, boil them down to their core components, so we can have them delivered by people who don't have any clinical background or any mental health background. And we've demonstrated that in our trials time and time again, that as long as people have reasonable interpersonal skills, and we screen people for those interpersonal skills, we can train them up with quite a brief treatment, a brief training of maybe up to a week, and with supervision, we can get really good outcomes. And that's really exciting because it means we solve that supply-demand problem of psychological interventions. This is something that we can deliver at scale. And the final point I'd mention of why we like it is circling back to Simon's point that an ounce of prevention is really important. If you can get in early, you can help people before they hit that inflection point where being off work turns into being off work permanently. So we're big fans of it. It's a straightforward intervention, but it gives you a decent bang for your bucks, and you can use it in a preventative way. I'll hand you back to Simon now, who's going to perhaps just finish off by talking through why we think it might be a good time to be thinking about all this type of stuff.
Thank you, Dean, and thank you for the Star Wars reference there. That's always useful, and the R2-D2 is a useful aids memoir if we ever struggle to communicate what it is that it's about. So just to look back to the white paper, so there's a lot of discussion at high table going on just at the moment about how we can tackle the epidemic of long-term economic inactivity. And just to pick out a few highlights from the white paper, there's lots to be excited about in there, but maybe a bit more that we can do to ensure it happens and actually gets its desired endpoint. So the white paper makes a really strong suggestion that the investment's going to happen with employment advisors. Those are going to be situated in job centres. So looking for work alongside looking after people's health problems is going to be part of the same conversation in there. And there's going to be some real-time and real terms investment. So the white paper currently pledges £240 million, and the proposal is there to reduce NHS waiting lists so that people get access to treatment more quickly, and actually to expand the mental health support that exists within the NHS. And it aligns with the historic shift that West Streeting speaks of all the time in the NHS about making this historic transition from treatment to prevention. I guess our concern is that this is laudable, but might be happening just a little bit too late and perhaps in the wrong place. So we worry that they're closing the stable door after the horse has bolted. And just to illustrate that point, I'm going to go back to the inflection point and what happens after people receive a fit note. And we can see that the inflection point happens at this crucial 28 days. And our concern is that all of the good stuff in the white paper seems to kick in after the inflection point, after problems have become entrenched and they're difficult to shift. And it all seems to be happening in the NHS or job centres. So the radical proposal that we have, and I'll leave this hanging here, and I'm really keen to know what Isabel and people that are in the room today have got to think about this. Rather than this happening in the NHS or job centres, this probably needs to happen in the workplace and from day one after someone receives a fit note. So I'm going to stop at that point and just remind people, if you don't get back to work in the first 28 days, it's increasingly unlikely that you ever will. So I'm going to stop sharing and pass back to our venerable chair. And thank you very much. And over to Isabel.
Dean and Simon, thank you so much. I've made loads of notes. Even though this is recorded, there are so many points there I wanted to pick up on. And I'm very keen on your workplace idea, but one issue that I can see coming up in workplaces is that people have won employment tribunals when their employer has been in touch with them while they're on sick leave. It's a very much a no-no, and HR departments are quite wary of being in touch with people on sick leave. How can we change the culture so that that becomes, because it's obviously key, how can we change things? I don't know if Simon, if you want to take that. Oh, yeah, you're on mute.
Get off mute. So you've asked me the real kicker there. So this is going to be a real change that's going to involve, it's a change in the culture, but also practice and, possibly even the law. And we've got some experience of this when thinking about how we might cite this, particularly in blue collar industries. So one of the important things is that there needs to be some separation between the employer and the person that's delivering this. So people can confide more readily if they think that everything's not going straight back to their employer. So that's really important. But the notion that the employers can't get in contact with someone in immediate period after the issue of a fit note is something we've really got to fix, and got to fix quite rapidly. And I don't know, have you got any thoughts on that, Isabel?
Yeah, I mean, I think you're absolutely right. I talk to a lot of people about the long-term sickness problem. Sorry, it's gone very dark here. A lot of corporates are very worried about it, and it is all about breaking the link between anxiety and depression and avoidance. And I think what you've talked about here is exactly what a lot of workplaces need. So I'm going to write about this, but Dean, I wanted to bring you in here because somebody is asking in the questions, have you done these recommendations to both DWP and DHSC?
Not as yet. So this is a work in progress. So not as yet, but we're opening up, talking to policymakers to do that. I noticed very quickly there was another really very good question in the chat around does delivering this thing over the telephone work as well as face to face? And I can't but help answer that question because it's something we've done a lot of work on and thought about. And the answer is a resounding yes. And it's a really surprising answer. So a lot of my clinical psychology brethren, until the pandemic came along, would have rather got their eyeballs pierced than deliver anything over the telephone. There'd be an argument, it's not going to work as well, and you can't build up that essential therapeutic alliance with somebody unless you're seeing them face to face. But we've got evidence that that's not the case. So there's lots of randomized trials out there, not done by York, but done by colleagues, demonstrating that face-to-face treatment and telephone delivered treatment for depression are equally as effective. There's absolutely no difference between the two of them. We know less about anxiety. What we do know suggests they're equally effective. Chances are you've got to do your treatment a bit differently to make it work without non-verbals and over the phone, but we build that into the training. We help people think about, as a coach, what you need to do differently to deliver your intervention effectively over the phone rather than face to face. We've also got good evidence that this crucial sense of how treatment works through this therapeutic alliance, you can develop that over the phone. You can develop that. Again, you need to work differently to do that, to demonstrate empathy over the phone. You need to be doing different things. But if you work differently, you can get to the same point. So it's good news because telehealth has all sorts of advantages in terms of delivery. People don't have to turn up at places. It's much more practical for people. You'd have to sort out childcare. It's a much more efficient way of delivering it to people.
That's really interesting. Have you worked with AI at all yet?
Not as yet, but again, a really good point. We're actively looking at that as perhaps the next step. Yeah. And that will be interesting to see how all that unfolds.
Very, very interesting in all sorts of ways. Right. How easy is it to access the behavioural approach via the NHS? Is it as successful by telephone as it is in person? We've done that bit. Is it easy to access?
So shall I speak to this? I mean, the last 20 years have seen a rapid expansion of talking therapies in the NHS, and there's a history lesson here. So the expansion of psychological therapies happened at the behest of Professor Lord Richard Layard, so an eminent economist based at the LSE. And he was mates with Gordon Brown, and he sold him the notion that the expansion of psychological therapies in the NHS would reduce long-term economic inactivity, because for the same arguments that I've made. So we've got lots more talking therapists in the NHS just at the moment, but there are still waiting lists. And I think that original aspiration of Lord Layard, that it was going to pay for itself 30 times over, has not really come to pass. So there are still waiting lists for psychological therapies. And in the suite of psychological therapies that are offered in response to the Layard report 20 years ago would include the type of therapy that we've spoken about. So behavioural activation is the slightly less well-known, slightly less glamorous cousin of cognitive behaviour therapy, where we focus on the B bit. Dean and I think that this is key to scalability. So behavioural activation is accessible in the NHS at the moment. It's just there aren't enough people to deliver it. There's still long waiting lists, and we struggle with this constraint of the mismatch between demand for services, which is almost infinite, and the capacity of the NHS to deliver that service. The mismatch between supply and demand is very evident. But you can sort of get behavioural activation in the NHS, but not quickly enough, I think is what I'd say.
Yeah. And so this might be where workplaces can step in. Actually, it's in their interest, isn't it, to get their workers back in to work. The first graph suggested that COVID's had a big impact, which is perhaps not surprising, but I think they mean mental health issues, was already the biggest cause of inactivity according to the graph, which I found more surprising. What is it about modern society that is driving this? Clearly, we can't just blame COVID. So that fairly massive question. Dean, what is it about modern society that is causing so many mental health conditions?
It is a very big question, and I guess ultimately we don't know. Some of it, though, is perhaps it's not just modern society. I think there is a contribution there, but yeah, there's a point that we try to get over in the work that life's difficult sometimes, and life is not about just always being happy, never feeling any anxiety. Certainly, modern approaches to interventions just say, look, life is really difficult, and actually, it's not about getting rid of anxiety or getting rid of this, but learning to tolerate and learning to lead a meaningful behavior in a way that's meaningful and valuable to you, even if you're not feeling great a lot of the time. And that's, I think, a key thing. Yeah, if you're going to do stuff that's important and meaningful to you, you're going to feel anxious. You're going to feel upset some of the time. So there certainly are changes that are probably making things somewhat worse. But the other bit is, it's part of the human condition is we struggle sometimes, and perhaps just recognizing struggling and not being happy and not being low in anxiety is actually part and parcel of life a lot of the time, and we shouldn't perhaps pathologize feeling miserable sometimes. It's part of the human condition.
Yeah. Simon, did you want to come in on that enormous question?
Oh, it's a huge one, isn't it? I'm probably more interested in what people have got to say in the chat than what I've got to say. But I don't know, ever it's been thus, there has been a rise of precarious employment. Isabel, you write beautifully about the accidental manager. There's so many crap managers out there. It's untrue. So I think maybe that drives it.
Yeah. I mean, that's a very huge, we talked about things at work that are causing you stress. That's the main one, actually. Given the supply shortage of talking therapy practitioners, would you recommend this as a career path?
Absolutely. Absolutely. It's great. And certainly coaches, the people we've trained up to deliver this, as we said, as long as you've got reasonable interpersonal skills, we reckon we can train you up to deliver this. And this could really solve that supply demand problem. So I'd certainly recommend it. Come on our training, we'll train you up. We're happy to train you up and get you delivering this stuff. We need more people delivering this stuff.
Right, here's a question that I don't actually understand, but I expect you will. Will the new Connect to Work programme using IPS help? Can we incorporate your methods into this delivery? Simon?
So there's a TLA there, a 3-letter acronym. So I think IPS stands for Individual Placement and Support, which is a model of workplace rehabilitation that's been around for a while. And I think it was imported from the US. So absolutely. So our concern would be that IPS isn't always psychologically informed. And we've got some good models that could ensure that IPS, which is a great thing, could probably be more effective if it were to embrace some of the ideas that we've introduced today. And as they say, we're open for business. So we're quite happy to have a conversation with the Connect to Work programme and offer a model of care that would be scalable.
Is this the programme that's being delivered through job centres?
Yeah.
Right, so that's a new thing. That's a good question to ask. Is there an argument for doing work with older teenagers, e.g. through further education colleges and sixth forms, before they start working life to enable them to develop coping strategies? The growing issue seems to be with the younger generation. And right at the beginning, you mentioned prevention is the best approach. Oh, that's very interesting. Dean?
I think that's a really good point. Absolutely, yeah. We're already thinking, we're working with colleagues to think about the delivery of behavioural activation with younger people, and perhaps picking out, there's different ways of doing it. So, and again, a bit of a debate about how best to do it. It could be a universal intervention, so you just deliver this to everybody. And there's other approaches to preventing problems And that's perhaps picking out people who might be at high risk. So you're a bit like we're doing here, a preventative approach. You're waiting for people to start to drift up into levels where they're showing some anxiety or some depression, and then focusing the intervention there. We probably don't know enough about whether to go universal or go for that more selective approach, but I think there's probably already enough evidence out there that getting in early with young people, delivering something very practical like this is potentially quite useful. The question would be whether you go universal or whether you go selecting people out who look to be at risk. But yeah, it's an absolutely great question, and we're already thinking about doing that work with some of our colleagues who work with young people at the university.
Yeah, because I talk to a lot of people about long-term sick leave, the impact it's having on the economy, and they always talk about the 18 to 24s as the fastest growing in economically inactive. Simon, I'm quite scared by some of the things you said, that people simply become workless. They're economically inactive if they don't get back. Are you already seeing this in the data you're collecting?
So we can look a bit more in the data. It's not that well described, and I'm interested to start a conversation with other people who are good at looking at workforce statistics. But the anecdote, and I think the historical lesson, is that the last 20 years have been really good at expanding higher education, getting people into university. So we've got lots of young people that go to university, but we've been less good at helping and enabling people to go into the workforce if university isn't the right thing for them. So this is where the needs come in. So not in education, employment or training. And there's obviously an uptick in the number of people who report psychological distress, end up going off and getting a fit note from their first job, or have a bad experience with a crap manager in their first job that's often precarious employment. And then that becomes their defining experience of employment. And once you fall into long-term economic inactivity at that early stage, I fear that it does predict a life of economic inactivity. And there's those early formative years, the first few years after you leave school. And historically, that's not what we've been good at. So I feel it's a big gap in the education system at the moment. And I am supportive, I think, of the general tenor of this question that comes there.
Yeah, perhaps just to add on to that is that young people are certainly a group we should be thinking about, but perhaps another group that we don't think about so often, but is young men, and focusing it on men, that often men don't get help until it's a bit too late. And the type of offer from the NHS in terms of talking treatment isn't something necessarily that men are willing to take up. And I think the way to think about that is not presume it's the men's fault for not wanting these treatments, but how do we build treatments that are much more accessible and attractive to men? And we've done some work with young people, some young men around that. I think that's a key thing as well, in making sure it's an intervention that's open to everyone, and we don't wait for young men to be in crisis before they seek help, which seems to be what happens too much at the moment.
That seems really interesting, Dean. What kind, do you mean things like doing activity-based talking? Things like, because I've heard about, women like face-to-face contact, and men are quite often interested in side-by-side. Or
that type of thing, sitting down with men and asking, what would the intervention look like? But we think this behavioural approach fits quite well with men because it's very practically orientated. It's building on strengths rather than their deficits. It's saying, well, set some goals, do some stuff, and you'll start to feel better. So we've adapted behavioural activation to work specifically with men in the NHS, so frontline NHS employers, and we've had some money from Movember, the moustache people, to do that. And we've had a great time adapting the intervention to make it more men friendly, and see the problem with the intervention, not with it's the men's fault for not wanting the intervention. So how do we get the intervention right for men working on the NHS frontline?
That's great. So we're coming to the end now. I just wanted to ask both of you, is there one tip or idea that you'd like people watching this to take away with them? Simon, I'm going to come to you first.
It's thinking about avoidance being an understandable psychological response. So if you went to your GP with a fear of losing the house, like agoraphobia, your GP would not prescribe staying at home for 4 weeks, because that would make agoraphobia really deeply entrenched and make it difficult to treat. So maybe think about being absent from the workplace, a little bit like agoraphobia. So you've got to do difficult stuff. You've got to expose yourself to challenging situations. So that probably needs to be at the heart of what we do. So think about it like we do other psychological difficulties. So think about this as agoraphobia.
Thank you. And Dean, closing thought.
Yeah, so it would be that if you boil down the behavioural approach into one sentence, we talk about follow the plan, not the mood. So have your behaviour governed by the long-term plan of getting well, not the short term of feeling rubbish, so I'm not going to do stuff. So I guess it's back to that avoidance thing, but follow the plan, not the mood. And as a clinician, you know an intervention's good if you use it on yourself. And I know every January and February in this benighted country, it's raining, it's miserable, it's cold. And in January and February, I follow the plan, not the mood. And it keeps my head above water.
Thank you so much to Simon and Dean. This has been a really, really excellent webinar. Thank you so much. Thank you everyone for tuning in. A reminder that you can re-watch this event. It'll be on YouTube and you can access it from the Watch Again section of the festival. And you'll be contacted by email when the video is ready to watch. And I'm going to write about it, I think, this week in the Financial Times. So it's been really useful for me too. So to Dean, Simon, and to everyone watching, and to the York Festival of Ideas, thank you so much.